right? And then the patient goes to theatre, you will wait in theatre, and you will cut. They will normally put a marking, say for example an X here, and that's a wire. So you will have to cut around here, around the wire tip. So you try and get an area about maybe the size of a ping pong ball, those who play ping pong or table tennis. So that's how big the specimen is. If you weigh, it's usually about 20 to 30 grams. Okay? That's how it is. So remember, these lesions are non-palpable, but you need to cut it. So how are you going to cut it? So you need somebody or something to guide you, and that's where this is necessary. So this procedure is called hook wire localization and excision. Whether it's palpable or not palpable, the same rule stands. You need a cancer-free margin of 2 millimeters. Okay? So what happens sometimes, or quite often, once, okay, you've taken the lump out now, you left it along with the wire. This goes back to the radiology department, and your colleague waits on the other end and will do a radiograph on that. So they will x-ray that specimen. Okay, well, you wait in theatre with the patient, and they will contact you and say, okay, this margin looks a bit close, maybe, okay? So you will have to cut a bit more in that area. Okay, because this area, the margin may be involved. But if this is nicely smacked in the middle like this, then you've probably done enough. Okay? That's what you have to do. Okay? Now, some clinical practice guidelines have mentioned that breast conservation surgery may not be suitable in certain situations. I've come across this. The Malaysian guidelines also has put this in print, but I tend to question this. Okay, I'll discuss this with you first, and you have a look at this. Now, generally, large cancers, more than 5 centimeters, all right? Because if you remember, we want a cancer-free margin. Once you've taken, say, half of a breast, what is left behind? Okay, is it acceptable to the patient, to her partner or husband? All right. So the problem of cosmesis is here. You can remove it, but if you've got not much left, is it okay? All right. Central cancers. Okay, we have cancers in the middle. All right. They say no, it's not probably advisable to keep it. Take the whole breast away. All right. Multifocal cancers, meaning you have more than one cancer in the same corner. Or multicentric cancers, you have more than one cancer in different corners. If you divide the breast into corners. Also in pregnancy. Okay, these are the rather challenging situations where they may say that breast conservation surgery may not be suitable. But I like to challenge this. Okay? Now, if the cancers are large, what do you do? So, remember the treatment of cancers as I outlined to you. Usually it's surgery up front, usually. But sometimes you can change the order around. So if you have surgery first, followed by chemo-endocrine therapy, because surgery is first, the rest after, they are called adjuvant, means after, right? Now, if you switch the order around, you either give chemo or endocrine therapy first, followed by surgery, you call this neoadjuvant. Okay? You're switching the order around. So what's the big idea of doing this? The big idea is you hope that by doing this now, you are making the cancer shrink sufficiently for you to change your advice or change the option to the patient. Now, yes, your cancer initially was 6 centimeters, but now, thankfully, with good response to treatment, it has shrunk to become 3 centimeters, for example. So from a 6 to 3, now you have more areas to save the breast. So you have an option of leaving a more acceptable looking breast. Okay, that's the big idea. Okay? But the problem is you must do the surgery within a limited time. The shrinkage is not permanent. Okay? Sometimes the cancer lump might completely disappear. And that's a problem. Then the patient will say, no, is it really necessary to have surgery? You know, cancer is totally gone? yes, it is. Reason being, the shrinkage is going to last usually maybe about 5 to 6 months only. If you don't do the surgery within that time, you'll be back to square one. You will come back. Okay? So you must educate the patient, you must get them to agree to come for treatment, surgery, even if the lump completely disappears for that reason. Otherwise, it's a wasted effort of undergoing treatment, especially if you have had chemotherapy, hair loss, some nausea, whatever, and for what? Unfortunately, this does happen. If you do not educate your patient enough, once the lump disappears, the patient disappears. You will never see them again. And that's why some of my colleagues, the surgeons, refuse to do this treatment. But I challenge them because if I can, my choice, I will not do mastectomy. If I can save 1 millimeter of the breast, I will do that. Because I think that's important for the patient. Okay? But not everybody agrees to that, unfortunately. So sometimes the outcome of a patient really depends on who the surgeon is. And even in PPUKM, or UKM Medical Center, we have 3 consultants. What happens to the patient in each, under different consultants, the outcome can be very different. Okay? So you all understand, yeah? Why I tend to favor this. But yes, there are patients who do. I had a lady recently from 5 centimeters. I told her you need a mastectomy, but if you go for chemo, it will shrink. So it shrank to 3. And I scheduled her for surgery. And she came out with excuses, I have to go home, I've got to see my mom, blah, 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 blah. She refused to have the first surgery. Okay, all right. So, and then the next time I rescheduled her 1 or 2 weeks later, she came up with other excuses. No, with this I have to go somewhere else. I want to try a new treatment, which is very promising, blah, blah, blah. And within those few months, from 5 centimeter, it went down to 3 after the chemo. And within the few months of back and forth doing whatever she was, all the excuses, it became 6 centimeters. She's lost that benefit, And now at 6 centimeters, she's completely gone. I don't know where she's gone. Okay, that's unfortunately the scenario sometimes. Okay, now, when you are dealing with breast surgery, you must remember the breasts are paired organs, right? So you have to not only manage one breast, you have to manage the other breast. It's probably something you need to think, that the idea is not just to save the breast, but how is it going to look with the other breast? Okay, the problem of asymmetry. Okay, let's say that this is the operated breast and that's a normal breast. If you leave it like this, can the patient be happy with this? If you just leave it like this, more often than not, they'll have problems fitting bras because it doesn't fit. One cup will be too big, the other cup will be too tight, and they have problems with clothing. So there are actually in the market something called fillers. For those who not be aware, there are fillers. They are something like the external prostheses, but they come in smaller pieces. So some companies can provide fillers. So maybe it comes like a C shape or like a moon shape. You can put it in when you wear to fill the bottom half of your bra. So that is available, but it costs probably about 300 ringgit, So that can be done. But obviously that is a temporary arrangement. Okay? But for some people they say that's good enough. Okay? That's fine. Okay. But for them they're not happy. So what are more lasting solutions? Either you make the right side bigger, meaning you put an implant or use a flap, or you reduce the size of the opposite breast to get symmetry. Okay, this can be done, but it will mean more surgery. But it's a more permanent solution, which some patients would be happy to take up, but some say, no, I've had enough surgery. I don't want to be under the knife anymore. That's fine. But more often than not, patients should be given this solution. They should be given this option, which unfortunately is not the case. Most women are not given the option. Okay? So remember I mentioned about more challenging situations. So if you follow some guidelines, they say if you have central lesion, then you should have mastectomy. If you have multifocal, if you divide the breast into quadrants, into parts of 4, if you have more than one cancer in the same corner or in the same quadrant, you call that multifocal cancer, okay? Whichever quadrant. But if you have cancer in more than one quadrant, you call it multicentric cancer. So it's just a matter of terminology, okay? So you have central cancers, multicentric, multifocal. So generally, some guidelines say these sort of cancers, these women should not have breast conservation surgery and they should undergo mastectomy. But I challenge that. Can you see? Okay. Now, if the patient has got a central cancer, you can remove the center, all right? Depending whether it is a deep-seated cancer or superficial. Right? If the cancer is superficial, then you have to remove the nipple areola complex as well. If you remove this, you can actually reconstruct the nipple areola complex later. Okay? If it is a superficial cancer. If it is a deep-seated cancer, you can remove just the cancer but keep the overlying skin. I try to do that when I can. Okay? So you can do that. And that area, normally there will be a fluid called a seroma which fills it up nicely, and it can be a satisfactory appearance. Okay? Now, if you have it in the same quadrant, you just remove them together, okay, for multifocal cancers. And if they are multicentric, so you have 2 scars, you remove them. So why do you need to subject this woman to mastectomy? That's my query. You don't have to, but obviously it's more work that you have to do. And of course, when you do breast conservation surgery, you must counsel the patient that 10 to 20% of them may need further surgery, as in a re-excision. Means the margin of the 2 mm was not achieved at your first surgery. So there is a 10 to 20% chance that you need a further re-excision of closed or involved margins. But I find that my patients generally are happy with that. They say, yeah, if you have to take a bit more margin, sure, rather than having the whole breast locked off. So if you want me to guarantee that no further surgery is necessary on the breast, the only guarantee is if you undergo a mastectomy. Okay? But I try to move away from that. So if the patient understands, cooperates, willing to accept,